Here is your question. Right. So if you have read and understood, considering this surgical and optional patient, kindly tell me if you can identify the structures, beginning with left-hand side image. If you can identify all the structures, please.
Ma'am, B is
what kind of
internal
image
carotid
is
artery.
this? Okay, but what kind of image are you looking at?
This carotid artery angiogram, ma'am.
Okay, so
Or
which
cerebral
vessel and its branches are being shown to you, and what does it show?
The left picture, it is mainly about internal carotid artery and its branches.
Okay, would you be able to identify the labeled structures from A to F on the left hand side, please?
Yes, ma'am. A is ophthalmic artery, and B is internal carotid artery, and C is antecerebral artery, and F is middle cerebral artery, and E will be frontal arteries.
F. Okay. If you can't, then we'll move on to the next one. Yes.
Yeah. D will be posterior communicating arteries.
Okay. Moving on to the right hand side image. If you can identify the structures labeled A to E, please, all of them quickly. A is, or if you can identify what B is, vessel B and C. Any idea?
Yes, ma'am.
Seems like a very
it's
common
basically
image.
Internal carotid artery. It's same. Yeah, it's basically internal carotid artery.
Yes, very good. And
giving branches to ACA and MCA.
Which one is MCA?
A is
Can you please tell me how circle of Wills is formed?
Yes, ma'am. So circle of Willis is formed basically by the communicating arteries between the basilar artery and the internal carotid artery. So the two vertebral arteries, after traveling to the foramen of magnum, they enter inside the skull, and they ascend upwards in the anterior to the medulla, and at the base of the pons, they form the basilar artery, which gives rise to branches, and this basilar artery gives rise to posterior cerebral artery mainly. Likewise, internal carotid artery gives rise to anterior cerebral artery and middle cerebral artery and posterior communicating artery.
Can you please tell me in which conditions carotid angiogram is ideal or should be done? Indications of carotid angiogram, please.
Ma'am, in case of stroke and headache, any tumors, vascular anomalies,
aneurysm, etc. Okay.
Aneurysms, yes.
Can you please tell me if you suspect that there is middle MCS infarct, what would be the signs which patient will present with?
Middle cerebral artery, the patient will be first presenting with aphasia, unable to speak. Then loss of hemiplegia involving the upper and lower limbs, one side. Likewise, the same side of the face, the lower half of the face will be
side. Yes. Okay.
Hemiplegia of the contralateral side. Likewise, lower half of the contralateral lower half side of the face is also involved.
Okay. Yeah. Kind of makes sense. Okay. Can you please tell me what would be the course of vertebral artery?
Yes, ma'am. There are two vertebral arteries. These vertebral arteries enters through the foramina of magnum,
Yes.
and they ascend upwards in the subarachnoid space, and they move anteriorly to the medulla oblongata. From medulla, they ascend upwards up to the inferior surface of the pons, and
through
inferior surface.
They pass through something very important. They traverse through something.
Traverse.
Yes, across the posterior arch of the atlas. Then what happens?
Yes, they traverse the posterior arch of atlas,
yes.
And they enter through foramina of magna. From there, they enter into the anterior surface, ascending upwards towards the medulla oblongata. From there, they reach the inferior surface of the pons.
They unite at the low
and form basilar artery.
Yes, a low border of the pons to form basilar artery. Yes, some mixing and forgetting. All right. Okay. Can you please identify the structures in this image from A to E, please?
Yes, ma'am. It is basically of the again carotid angiogram. The A will be of middle cerebral artery, and B will be of internal carotid artery, and that is giving branches.
Which branches?
E will be of
yes,
and middle cerebral artery, ma'am.
Okay, can you please identify this image?
Yes.
This is the most familiar one. Okay, A to F, all the structures.
Yes, ma'am. So basically, A will be internal carotid artery, and D will be middle cerebral artery, and E will be posterior cerebral artery, anterior cerebral artery, and it is the communicating artery. Likewise, C will be vertebral artery, and B is forming the C will be the
C is anterior ACA, and E is basilar artery.
B is basilar artery. Yes.
Yes.
C will be
B is anterior communicating artery. Yes.
Yes.
Okay.
And
so what is this?
That is internal carotid artery, giving rise to M.
Okay. In this image, there is arrow pointing at something. Can you identify the structure?
So middle cerebral artery, ma'am.
Can you please tell me, okay, when a patient presents with Barrett's aneurysm, then that patient is most likely to present with another condition as well, another familial condition. And you mentioned the name, please?
Polycystic kidney disease.
Yes.
Autosomal dominant polycystic kidney disease.
Yes, especially in adults. Good. Thank you.
Sorry, ma'am, I completely messed up with the images. So sorry.
Okay, this is the last one. I thought that was the last one, but this is the last one. Can you please, there are 4 arrows. I have tried to rub the answer. So 1, 2, 3, and 4. Please identify. This one is ICA.
Okay, that's internal carotid artery.
Yes. This is MCA. This right and this is left. Which one should that be? It's MCA. This is also MCA.
Yeah.
this is ACA. Okay, now you have
ACA,
to imagine, yes, that's what it says. You have to like imagine the blood supply in the brain and then tell me how it divides, what are the branches, and each branch supplies which part of the brain. Can you
regarding circle of William or from the vertebral and internal carotid arteries? I didn't get the
from
point.
these vessels?
Okay.
ICA,
So basically,
yes, it divides
vertebral
from
arteries
yes.
after entering, they form the basilar arteries, and this basilar artery gives rise to mainly anti-inferior cerebellar artery, labyrinthine arteries, pontine artery, superior cerebellar artery, and posterior cerebral artery. So they supply mainly the occipital lobe, they supply the midbrain, they supply the midbrain, pons, medulla, and the posterior occipital lobe. Whereas internal carotid artery, they give rise to anterior cerebral artery and middle cerebral artery, and anterior choroidal artery along with the ophthalmic arteries. So this supplies the midbrain. I mean, this supplies the frontal lobe mainly, and the forebrain.
Okay. Good. Thanks. Right. Someone is asking. Right. So if you have read and understood, considering your surgical and administration,
Yes,
kindly
madam.
tell me if you can identify the bones you're looking at or the image that is in front of you. Can you identify this 8, please? Okay, before that, can you please tell me the boundaries of the middle ear?
Boundaries of the middle ear.
Yes,
Madam, the middle ear has a roof. It has a floor. The roof is formed by the
Tegment,
tegment. The roof is
tympani,
formed by the
yes.
tegment.
Yes.
The floor is formed. Floor. The floor.
Yes, please.
The floor is a relationship with an with ICA.
Okay, if since this patient was a child and has presented with otalgia and there was this oral discharge as well, can you please tell me how the infection spreads or comes out or it spreads to the middle ear, especially when children have or the youngsters have upper respiratory tract infection? So how the infection reaches the middle ear?
It spreads to the eustachian tube till the middle ear.
Yes. Okay.
And
Okay.
from there it can
By
go in like
yes, by involving mastoid ear cells.
Okay, madam.
Yes. Okay. This is what I wanted to know. Would you be able to? You can't tell me the boundaries. Okay. So can you please tell me how many subarachnoid spaces or cisterns there are in
Madam, there
human?
is a cisterna magna.
Yes.
There is a prepontine cistern, and then there is the interpeduncular cistern, and then
Yes.
there is a suprasellar cistern.
Okay, and there is one membrane, if you can tell me. Liquid membrane. Okay, can you please tell me how the cerebrospinal fluid is formed and carried out?
Madam, it is
or
formed in the
transported?
lateral ventricle. Then,
Yes.
through the lateral ventricle, the foramen of Monro, it goes into the third ventricle. From that, it goes into the fourth ventricle to the aqueduct of the Salvius.
Yes.
And then through two lateral foramen of Plashka, and to one medial foramen of Majandi, it goes into the subarachnoid space. Afterwards, into the arachnoid villi, and
Yes.
then into the superior sagittal.
All right. Whenever there is obstruction to the flow of CSF, where it takes place, what is the most common place?
It takes place in the arachnoid villi. Subarachnoid space, sorry.
Even maybe before that, foramen of Leshka, maybe there. Or aqueduct of Sylvius, sorry, aqueduct of Sylvius. All right, can you please tell me what do you understand by the term Arnold-Cherry malformation?
Madam, this is basically the cerebral tonsil which is coming out to the foramen magnum, and
Yes.
it basically stops the flow of the CSF. So this is a malformation.
Oh, very good. Okay, can you please tell me what is meningioma and how can it be diagnosed?
Meningioma is, okay, madam. Madam, this is a tumor of the meninges, and
Okay.
it can be diagnosed through an MRI brain with a contrast.
Good. From where does it arise?
It arises from the arachnoid cells.
What structures it can compress? Meningioma we are talking about.
Depending on the position, it can compress most commonly the parasagittal sinuses.
Very good. Okay, what are the area of the brain which is affected?
The area is the primary motor area, that is broad main area 4.
What are the clinical features with which patient would present?
There will be contralateral paralysis of the lower limb.
Very good. Okay. What do you understand by glioblastoma?
Glioblastoma is, madam, a very tumor of the meninges, and
okay.
This is the most
if
aggressive
you
form.
Take an image, what contrast can be used to get a good or enhanced image of this tumor?
Gadolinium.
Very good. Right. Can you tell me few differential diagnoses?
Madam, it can be metastasis, abscess,
yes,
glioblastoma multiforme, infarct,
yes,
and there can be
confusion and demyelinating disease.
Yes, madam.
Okay. Can you please tell me the course of oculomotor nerve?
The oculomotor nerve.
Yes, please.
Madam, the oculomotor nerve.
It supplies which muscles, and what happens if there is a paralysis of oculomotor nerve?
Madam, it supplies all the muscles like the medial rectors, the inferior rector, the superior rectors, the inferior, except the lateral rectus and the superior oblique.
All right. What else does it carry? Yes, levator palpebrae superioris and
levator palpebrae superioris and the sphincter pupillae. Yes,
and sympathetic fibers too. Mueller's muscle and sphincter pupillae. Okay. Yep. What do you understand by the term tentorum cerebelli?
Madam, this is a projection of the dura of the meninge, which basically is over the cerebellum, and it's like it separates the cerebellum from the posterior cerebral hemisphere in the posterior cranial fossa.
Can you please tell me its attachment?
Madam, it is attached posteriorly in the transverse sinus groove of the occipital bone. Laterally, it is attached to superior part of the petrous part of the temporal bone, which ends anteriorly at the anterior and the posterior clinoid processes. The medial border are free, forming a notch through which the midbrain protrudes.
Okay. Can you tell me what you understand by the term false localizing sign?
And this is a like a neurological sign which shows damage not related with the anatomical position of that specific
And it's most
lesion.
commonly occurs in abducent nerve
Abducent nerve.
palsy due to increased ICP. Okay, can you please tell me this oculomotor nerve? It's most commonly pressed against which structure?
Ma'am, to the attached border of the tentorium cerebelli.
Yeah, which was part of the template. Yeah. Okay. What are the last question? Because since you can identify or tell me the boundaries of the ear, so what are the conditions with which, or what are the tumors of ear that you are aware of?
Tumors of ear.
Yes. How would you classify? The ear is a big term. See, so there is middle, internal ear, middle ear, and external ear. So how would you classify the conditions of ear?
I'm sorry about it.
Okay, you can tell me next time. Thank you. And here is your question. Let's see what it is. So here is your. There are 2 slides. Once you are done reading this one, please tell me. I'll move on to the next one.
Okay. Okay.
Are you done reading this one?
Yes.
Yes. Once you're done, then we'll begin. So it doesn't matter. Take your time. In exam, you'll be given whole 9 minutes to prepare your station in one day.
Okay.
Yes? Okay, I'm starting your timer. And considering a communication skill station, can you begin?
Hello, I'm Dr. Muhammad, one of the surgical institute doctor. I'm working in downtown hospital with Mr. Man. I'm calling us to speak with the cardiothoracic surgeons to ask him to accept a referral for a patient who has been polytraumatized and also is widened mediastinum on chest X-ray. May I confirm who I'm speaking to, please?
Yes, I'm Mr. John. Can you please summarize your case?
Okay, 23 years old male who's been diabetic and has been on RTA motorcycle. On examination, his GCS is shown to be 14 and also his blood pressure is 18/80 and his heart rate at 120. Chest X-ray was done and has shown that he has widened mediastinum with pleural effusion. Chest drain was inserted. Okay. And also we know his hemoglobin has been 8 and also with an APG was shown to have low bicarb rate and also it's metabolic acidosis as his pH is 7.32. Also in examination we noticed that he has swelling in the left thigh. We started with IV fluid resuscitation, and also we did cross-matching of blood with 6 units, but not transfers yet. Also, when we did the left femur X-ray, who showed fracture in the femur.
Okay.
We didn't do CT scan as it's not available till 3 days later.
Okay. So is there any abdominal issue for this patient?
Yes, we did an abdominal X-ray. It showed that he has absence salt shadow.
Okay. So does he need any surgery for this?
Yes, as this may indicate he has intrafluid collections, maybe that he is intra-abdominal bleeding. So yes, he might need a laparotomy.
Okay. So what are you going to do about his BP?
About his what? Sorry.
The
Blood
blood
pressure.
pressure.
Okay. I will start fluid resuscitation. After it's not response, I will give him the blood transfusion. But
Yes.
I will not make the blood pressure too high as this might increase the bleeding.
Okay. So what are the abnormalities in his blood test?
He has low hemoglobin level, and also his ABG shows that he has metabolic acidosis, and also there is a slight increase in C-reactive protein.
Okay. And what would you do for the cervical spine of this patient?
I will use a hard collar.
Okay. If heart collar is not available, then along with it, what else you can do to stabilize the spine?
I will use the sandbags
And
or
tape.
maybe almost line tape. Yes,
Yes.
and tape.
Okay. And also there is a swelling in his left side of the thigh with fracture. So what would you do for this leg?
This patient most likely have compartment syndrome. Then I will examine if there is any sign of increased compartment pressure. Then I will differentiate them.
Okay. And how would you fix his fracture?
I will use Thomas splint.
Okay. Why this patient is having acidosis and what kind of acidosis he is having?
This patient is diabetic, so he might have actually DKA, most likely metabolic acidosis, or it could be due to compartment syndrome.
Okay. What kind of shock would you suspect in this patient?
I would suspect hypovolemic shock, and also I would suspect hemorrhagic shock.
Okay. So what about his GCS? His GCS was 14 at presentation. So is there anything else you need to do?
I will keep monitoring the patients hourly. If there is any deterioration, then I will manage accordingly.
Okay. And
Yes. ABGs, how would you correct that? What measures would you take? Do you think the management
for the if the patient is in DK, then I will start giving IV fluid, normal saline. Then I will ask for electrolytes. I will see the potassium level, sodium level. Then I will start giving insulin according to the weight.
And who else would you involve in the care of this patient?
I will involve the anesthetist and also the IT or extra.
Okay. Okay. And what if this patient would have had hyperkalemia? Then how would you treat his hyperkalemia?
Having hyperkalemia, then I will give him insulin. Also, I can give him
Yes. These management tips should be on. Yes. The fingertip.
yes.
We'll come back to this.
So what? So you have inserted a chest tube for this patient, and it has what has it drained?
Actually, I don't have this information right now, but I will check and call you later.
Yes, sure.
All right. How this station time has ended? So how this station should have ended?
I summarize.
Yes, you'll summarize to the consultant all the advices consultant has given. Yes, and yeah, what would I say that it wasn't really completely prepared. There was like certain questions which could have been completed like in a lot more good manner. And do you think these 6 units of blood which are standby, would there be enough or would there be excess infusion of blood transfusion? How to determine?
His hemoglobin is at.
Sorry?
It's according to the vital signs.
Okay.
According to the vital signs, the patient has his blood pressure is now is 100/80.
So
and
what are
yes,
the
it might be enough.
complications that can arise because of the transmission of excess blood or excessive blood transfusion? Can lead to what complications?
It's lead to fluid overload and heart failure, and also can lead you to hypothermia and hypocalcemia and
Yes.
hyperkalemia.
And iron overload as well.
Yes.
Okay, good. Do you want to give feedback, Dr. Snehal?
Yes, he was very well prepared. And our only 1 or 2 questions, like why he patient has acidosis, is the metabolic acidosis due to maybe compartment syndrome, and also the patient is diabetic. So the diabetic ketoacidosis also we have to keep in mind.
Keep in mind and rule out. Yes, good.
Yes, yeah.
Thank you. And here is your question. Right. So if you have read and understood considering this communication skills patient, kindly begin.
Yes. So I'll enter the room. Hi, good morning, Mr. Smith. I'm Dr. Snehal, one of the surgical doctors in this hospital, covering for Mr. Mann. So I understand that you have been waiting here for an investigation to be done today for your legs. Is it right to talk? Right time to talk to you?
Yes, miss, I want an explanation about my situation here. And I want to
Yes.
also see the consultant.
Yes, I'm so sorry, Mr. Smith. I'm really very sorry that although you were planned for this case, the case needs to be shifted or needs to be done tomorrow, as the consultant was called up for an emergency, fortunately. So very sadly, he's busy right now. Even if I call him, he would not be able to pick up my call.
So
But,
are you saying then, are you saying that I have an case or OT listed which was postponed? I am confused because I was told that I need to have an angiogram done first to evaluate my problem. I am confused.
Yes, Mr. Smith, so sorry. You were planned for an angiogram. We called it, it is a test we do in
Yes,
which
yes,
we
that's why I heard. What kind of doctor are you? I am very angry right now. You do nothing about my history and nothing at all. And now you're coming and telling me that I have a surgery and which is postponed. I am very much angry. I want to speak with Dr. Mann.
so sorry. I understand that you are very angry, and I can see that how you must be feeling right now. But let me tell you that this angiogram, it is a test which needs to be done in an procedure room in which we inject a small amount of the medicine into your vessels, the blood vessels, and then we can evaluate you better to see the vessels. Fortunately, the emergency came up, and the doctor was called, my consultant. So we have shifted this procedure for you. We have planned it for tomorrow, and I'm really, really sorry for the same. So can I please offer you something to eat? You must be really very...
No mood of eating, doctor, but because I was told yesterday that I have a dead or dying limb. My leg is going to die, and I need to evaluate by a test. I don't know what is doctors call it, CT scan, CT angiogram. But now you are I think my case is very much. And how will you compensate for that?
Good. Yes.
Yes, I'm really, really sorry for that, Mr. Smith. But as we see the review, which that your blood sugar is 7.8. Also, basing your previous charts, I cannot see any ulcer or gangrene like this. So although your case is also important for us, if some emergency comes which are really life saving, then our consultant has to attend them first. So those cases need to be prioritized over the case like yours, and I'm really, really sorry for that. So
but how will you do? At first a doctor evaluate me, and why my pulse was absent, my both limbs. He said that my pulse was absent in both limbs. Isn't that mean my leg is dying? And why are not you shifting me to another hospital where this procedure can be carried out emergently?
Yes, I'm really sorry for the situation, and if the need arise, we will not let you suffer, and definitely we will shift you to the other hospital, and I would accompany with you myself if the need arises. So right now, as soon as the consultant is free, I would arrange an appointment of him with you, so your case would be better discussed with him. Is it all right?
No, I'm not. My leg is hurting a bit. What can you do? You never ask about my pain. Why my leg is painful? My leg is very much painful and hurting very much. I'm anxious. I cannot breathe even. And you are saying me my what is cancelled. I want to be scheduled right now, and I want to shift it to another hospital.
Yes, I'm really sorry for that. However, I'm really afraid that if you really like, if you want you to shift right away to other hospital, the other doctors would start your studying your case from the beginning, and that would take more time. So
What about my pain? What about my pain?
Yes.
Are you not going to do anything about my pain?
Yes, Mr. Smith, I can really see that you are having lots of pain. So I would be giving you certain more injections for the pain, and I would change the painkiller you are currently having to the the stronger ones. So it would give you a pain relief, and also I would be adding certain more medications that would cause relief of your symptoms, or they would they would assist in release of obstruction of your vessel. Is it all right? I hope I'm clear to you.
Yes, I'm clear, but my pain is not reducing. And some doctor came that he said my maximum dose of painkiller has been already given, and he need to puncture me in the back. Is it correct, ma'am? I don't understand it. Why he need to puncture me in the back?
Yes. So there is this another form of a mode of painkiller which we can give if you have really severe pain, and in that case we make a small we insert a small tube your back, and through it the painkiller is given, and it is usually very effective, and usually there are no side effects of that.
Need to be injected. My leg is hurting very bad, and I'm very much I'm feeling very much pain. I think you understand my concern.
Yes, Mr. Smith, I'm really sorry for that, but and I really apologize for this situation. However, before giving this kind of painkiller, I need to involve my consultant, and after taking his permission, then only we can arrange you for this kind of a painkiller. So till then, I can give you the another painkiller, which is more stronger, and it will give you a pain relief. So
Okay, ma'am, proceed.
At the end,
yes.
patient
So
will not
let
be
me
happy and will again ask for pulse. What is pulse?
Yes. So we have this patient advice and liaise system
License system. Good.
in our hospital.
Yes.
So you can
all the angry
definitely go and
patients,
they can
yes,
guide you.
Yes, you'll give the form. You'll say, okay, if you want to still go ahead with the complaints, you have to fill this form in. Because here patient will not be happy because patient is aggressive. And one question that you could ask Dr. Hasigazama, you could have asked the doctor to, you do it. Why don't you do it? The procedure on me. So that was one question.
Okay, ma'am. Sorry.
Yeah.
Sorry,
No,
I
that's
missed.
okay. Yeah, that you could have asked. And this another argument you could have given, that since you have been rescheduled for the next day, so you want this candidate to give you guarantee. That what is the guarantee that again you will not do the same thing with me tomorrow morning? So here candidate is not supposed to give you any guarantee, but this question will be asked if you're doing arthroscopy or this one. So the patient will say, okay, what is the guarantee that tomorrow again you will not do the same thing with me, and again my scheduled procedure will not be cancelled. Yeah. And that was rightly you asked, give me another doctor, and she answered it rightly, that it will be time consuming. Good, nice. So thank you, both of you.